Check, 1, 2, 1, 2, check.
Okay. We'll make a start because it's 5 past, and I know that everybody's coming away from clinical duties, if not going to be stuck for a number of hours. So my name is Andrew Steele. I'm one of the intensive care physicians. I'm the medical director of the Toronto Western Intensive Care Unit, and I'm one of the leads for this project, which is the National Early Warning Score project at UHN. And I've been asked to give rounds today in order to not just introduce this. This is now moving in the phase of implementation across the organization. The go live date is October 7th. And so there's a number of these educational rounds that we're providing for nurse practitioners, for residents and fellows and attending staff across the organization. So given the invitation, I'm happy to step up and talk. I'm going to talk very briefly and take some questions. And it's really about what we need to know if we're admitting patients in a couple of weeks' time on October 7th, and just how this may change your workflows. And a lot of that hopefully will just be a discussion amongst us all. So what is this really about? This is a generic presentation that we have that's going to go out across all educational programs, to all the education leads in every division across the city. And just to talk specifically to the audience today, we all know that critical illness is a multi-system process. I don't need to tell you this. Why am I standing here today? Some of it's about the invitation that I got, but also it's because multi-organ transplant is the biggest user in the organization of the critical care response teams. So multi-organ transplant program here at Toronto General Site, I think accounts for around 40% of the activity of that team. You account for roughly a third of the new activations, the new consultations across the whole of the Toronto General Site. Of those new activations, around a third of them will go and be admitted to the intensive care unit here. Around 15% of them will be admitted to the level 2 unit if they weren't already there in the first place. In addition to accounting for around a third of the new activations of that team, you account for around 25% of the activity of the Code Blue team here as well. I don't have the outcomes to share with you of those patients, but I can tell you when we looked at the activations across one single year at this particular site, there were around 2 patients who got to go home alive, and the rest didn't do very well indeed. I think the higher the acuity, the more complex those patients are, the less likely they are to have a favorable outcome. We look over the course of the last 5 years across UHN, there've been roughly 14 SSE1s that resulted in a patient's death, and 11 of those deaths were believed to be responsible for failure to recognize that a patient was sick and a failure to provide an adequate response to prevent from getting sicker and dying. So 11 patients over the course of 5 years across just the acute sites is a significant number. And that was what led to the development of the escalation of care matrices across all divisions and all programs. So everybody here should have a good working understanding of the escalation of care matrix for the multi-organ transplant program. And what builds upon that is recognizing who is sick and then responding to who is sick. And then part of that response will include your own response to the bedside level, your own expertise, which is critical, that understanding of that patient, and then mobilizing the organization's own resources, such as your rapid response team, your critical care teams, and hopefully not, but if you need it, the Code Blue teams. So we recognize the key to this response is early detection, which is where NEWS2 comes in as a track and trigger system, making the correct diagnosis, which is where bringing the right resources to the bedside, those people who have expertise in that patient's condition, who know that patient, and then providing a definitive treatment. And I think the key to this is bringing guys like yourself early to the patient's bedside, rather than someone like me who doesn't know that patient, doesn't necessarily know the nuances of that patient's condition, but I can provide an endotracheal tube in a hurry if you need it, and an armful of norepinephrine. I'd rather not get to that point. And the goal of NEWS2 is to escalate as that patient starts to get sicker, to give you an idea perhaps where, again, even the nuances and what you understand about your patient's condition are somewhat lost in all of the data that you have, and certainly helpful to those perhaps amongst you or amongst your own teams who do not have that level of in-depth understanding because they may not have your subspecialty experience, because they're rotating staff, perhaps new staff, or it's just one of those days we've got a new patient you're still getting to know. And hopefully this will be another asset to your care path and your workflow. So for those of you who not had a chance to have a look at it, the NEWS2 system is something that began around 12 years ago in the United Kingdom. It's an aggregate scoring system, and over the course of the last 12 years, it has been redefined, and it's now in its second iteration. So the aggregate score is a risk score, and it's calculated from 6 vital signs and the need or not for supplementary oxygen. So it's the standard ones you might expect. It's your oxygenation, it's your respiratory rate, whether you need to be on oxygen or not, but then the other vital signs would be the systolic systemic blood pressure, your heart rate, your level of consciousness. And what is critical to this is whether there's a new change in your level of consciousness, whether there's a new change, new confusion. As we all know, the new confusion could be a sign of poor cardiac output, can be an early sign of sepsis, a number of other conditions that preempt a worsening and early death, and then your temperature as well. There's no doubt that this system, as it's been sort of morphed over the course of the last 12 years, is really about picking up early sepsis. And then the addition of having different oxygen scales was really to account for the fact that the majority of adults who are admitted to acute hospitals will have COPD, and exacerbations of COPD being a very high proportion of those. And so the goal is to be a little bit more sensitive to those patients rather than less. And if you have a higher score, so when you have scores of 5 to 7, a score of 7 on the NEWS2 scale would predict a 33% increase in chance of being admitted to the ICU or of inpatient mortality. Now, this is a general adult critical care prediction score. It isn't about focusing in on patients with hematological malignancies. It's not about patients specifically who have had a solid organ transplant, but it has been tested and validated across a general adult patient population. And then some individual research has been done for multi-organ transplant, solid organ transplant patients, for those with hematological malignancies, those that have cardiac disease, for those that are on dialysis alone but haven't had a transplant. And I think that it does apply across the populations that we have here at Toronto General Hospital and Toronto Western Hospital. I think there's applicability to it to Princess Margaret and to TRI, where it's going to be rolled out. Some of this we know from the literature, some of this we know from speaking to colleagues at places like Hamilton Health Sciences and a number of the other academic and community partners that are around Toronto and across the province and in countries like the United Kingdom and Australia. Some of the things we focused in on in terms of the education for some of the more junior staff is just talking about why respiratory rate and why respiratory deterioration is critical in this, and recognizing, for those of you who work with patient populations that have respiratory failure, you'll know this very well, that if you have even small changes in your respiratory rate, these can be very predictive of worse outcomes in patients and early signs of serious clinical deterioration. So respiratory rate, even small changes here will score you very highly and will result in an activation, particularly if coupled with deterioration in oxygen saturation or other signs of sympathetic activation, such as the heart rate and the blood pressure. As I said to you before, the second iteration of NEWS is to add in this oxygen scale so that you can be more sensitive to those patients that have hypercapnic respiratory failure. And it's important that we select the right scale when we're doing the score for these patients. And then whether you are on supplementary oxygen or not, this isn't whether you're on it or not, obviously. This is about whether you need to be on supplementary oxygen, and that confers a higher score and that advances you up the scale. Level of consciousness is critical. This is where it's a little bit difficult for those patients that we look after at Toronto Western Hospital. You have post-operative patients in the neurosurgical services, those patients who are what are essentially as a regional referral center for stroke and other neurological conditions. You may have patients in the multi-organ transplant program, particularly in your level 2, that are there because there's an alteration in their level of consciousness, because there is an established baseline level of confusion. And this is where it's a little bit difficult, but the NEWS2 scale brings in this concept that you're either alert and you have all of your faculties, or you do not. It's a binary scale, and they do talk about having confusion and then what essentially is a modification of the AVPU scale. But fundamentally, you're either alert or you're not. And if it's new onset confusion, that would give you a score of 3, and that would advance you very highly in terms of the risk of deterioration and gives you a very high baseline score. This is something I think that we're all going to have to adapt to a little bit. You're going to have to recognize the fact that somebody who has, you know, an established confusional state, perhaps because they're on high doses of steroids, perhaps because they have an infection that you know about already, that you're already tracking, and we'll have to reset in our heads and amongst the care team, there has to be that ongoing conversation that this isn't new confusion, that this person's baseline scores are sitting 3 or 4. But this is something that's said in a general adult admission or someone who's newly admitted to your service through the emergency room, if they have new confusional state, and you know that that portends to a worse outcome in that patient. So what this builds in is it builds on those escalation of care pathways, those escalation of care matrices that every program, every division has. If you're not using those, then this is an opportunity perhaps to refresh your memory and refresh the program's use of these, because the idea is that you have a certain score. The higher the score, the bigger the mobilization. So a low score would be nothing really doing. You have the continued monitoring, continued vital signs at the same cadence that you normally would, and that might be Q shift, Q8. I think the majority of patients, or the highest frequency, at least of patients' vital signs scores in our acute sites, is every 4 hours. And you would continue in that vein if you saw a patient with a score of 0 to 4, 1 to 4 rather, as opposed to an acute person who suddenly had a score of 3. As you start to rise up, you enter into the yellow section, and then further up, orange, and then red. So the color coding is the same as our existing escalation of care matrices that match to the NEWS2 scoring system activations that they have in the UK. And so if I score 3 in a single parameter, that might be that my heart rate has changed from 90 to 120. And exactly as you would do now, you might be observing that patient a little bit more closely. You'd want a decision-making period. Is this suddenly a one-off because their hydromorphone and the post-operative patient has worn off and they need more? Is it that they made the effort of going to the bathroom and back and that was a little bit more than they could have coped with? Or is this someone who may be deteriorating? And so the response to that in our general ward patients, and perhaps your ward patients as well, that we'd instigate this period of observation to do hourly vital signs for a period of 4 hours where you'd make a decision. You may make that decision within 5 minutes because you know the patients well, you know why they're deteriorating, you know enough about them, and you may want to advance their care and put them in your step-down unit and move them. And that's maybe what the general surgical patient population are going to do. But all of our clinical directors are committed to be delivering this 4-hour period of observation doing 1 hour vital signs. If the patient deteriorates significantly and they're already scoring 5, then a more urgent response will be warranted. And that urgent response may be something that is beyond the program, beyond the division, beyond the ward or the level 2 unit. You might want to activate, we would encourage you to activate the rapid response team at this point so that they can see the patient, assess the patient, start managing them and supporting you as you see fit. And if they were scoring 7, then you'd be in that red zone. At this point in time, those patients would probably warrant continuous monitoring. You'd want your patients in your level 2 unit if you were a program that had access to it. So the multi-organ transplant program here, general surgery here, the level 2 units at Toronto Western Hospital for neurology and neurosurgical patients is more than capable of doing continuous monitoring and running inotropes in doses that we would all consider to be respectable. And you might want to move that patient at that point in time. Again, this should map out and align with the existing practices that you already have. It just makes it a little simpler. It's a little bit simpler to remember than some of the escalation of care matrices that some programs and divisions are using right now. But to think of it in terms of the gray zone, it can be business as usual. The yellow zone are those patients that you might want to be huddling and talking about as a program, as a team, and saying, not sure where this is heading. This guy is suddenly breathing a little faster, oxygenating a little worse. I'm sure this is already happening. Your residents are calling your fellows are calling your attendings, the nurse practitioners are seeing the patients more frequently with you. And then at 5 and 7 are the sort of thresholds we would expect a more system-wide response where your intensive care teams, your critical care response teams are already getting involved. This maps out when we look at the data of what programs have used and when they've called over the last 5 years. It's a little hard to sort of follow over the sort of 2-year period where the transplant programs were a lot quieter, but we think it corresponds with this proposed sort of matrix. So what does that mean in terms of workflow? If you're on call and you're seeing patients in the emergency room in the middle of the night, or you're admitting patients in the middle of the afternoon, what does it really mean? All that's going to change with your workflow is that you're going to be adding in an additional order. You're going to have to make a decision as to which oxygen scale this patient needs to be monitored on. All the admissions order sets will be changed so that your vital signs, when you select them, each time a full set of vital signs is performed, you will get a NEWS2 score, but you have to put in the NEWS2 oxygen scale. You have to select that. So if it's me with community-acquired pneumonia or some dysrhythmia, whatever's brought me into hospital, maybe it's alcohol withdrawal, I don't know, you would select NEWS1 for me with just a standard vital signs. What that means, instead of selecting your oxygenation targets, this should be exactly the same. You'd expect me to have a normal oxygen target. You'd expect me to need supplemental oxygen at the same point in time. You wouldn't expect me to need that hypoxic drive. But if it's me, 60 cigarettes a day and 20 years time, then you might want to think, well, this person does have features. You already know that I have features of COPD. You already know that I have hypercapnic respiratory failure. And so you just select NEWS2, which is actually the same as saying, I want a lower oxygen target for this patient. I want 88 to 92, and it will be different. I think you're already doing this. You're just going to be ordering it in a different way. Likewise, if myself or Martin Erner or someone discharges a patient and does transfer orders, so the patient leaves the ICU and goes to the step-down unit, or I send somebody out of the Western to the step-down unit there, all I need to do there is I do my transfer orders. I need to add in the CCRT follow-up order, and I need to add in the NEWS2 oxygen scale for you. And then when the patient arrives, those orders are signed and held. I think that's the workflow you're already operating on now. It's certainly what we do at Toronto Western. And so I just add that in there. And in fact, what I will get as I transfer that patient out, I'll get a prompt. Have you done the CCRT orders? Have you done the NEWS2 orders? And it'll be one click and it's done. As you admit the patient through the ER, you're going to do your order set exactly the same way. You're going to select your oxygenation targets. They're going to align with this, but you're going to have to put in a NEWS2 oxygen scale. And when we go live on October 7th, that will already in place. At 1 minute past midnight, that'll be in place for you. If it's not working at 1 minute past midnight, feel free to call me in about 6 or 7 hours. So what does that look like? So this is in the eye of the beholder. So we already have the trial running and have done for the last nearly 3 weeks on 14 Eaton in the GI unit there and on 8B Fell at Toronto Western Hospital. So this is what they see. So although this is a mock-up, I can certainly log into Epic and show you if you like, but this is what you will see. This is the storyboard. And for those of you who don't know the Epic vocabulary, that's the one thing I've had to learn a lot of over the last 6 months of this project. So when the digital guys say they're talking about the storyboard versus this view or that view, this panel versus that order set, I'm beginning to understand that language now. So this is what you get. You have this, and you'll see you've got the isolation data, you'll have the patient's allergies, and then beneath all of that, you'll have the NEWS2 score. If this is blank, it's because a full set of vital signs, including the oxygenation scale, including whether they're confused or not confused, has not been done in the last 12 hours. At 12 hours, it'll clear. And if the orders aren't present, it will not populate it either. But otherwise, you'll get this. If you hover over it with the cursor, then what will pop up will be what you see on the right side. So it'll pop up with the aid memoir as to what to do with it, some of which I think is obvious because it will be color-coded as well. You'll have your own escalation of care matrix to follow. So for some people at 5, it will be calling the attending, it will be notifying them. For other people, it will be escalating to the nurse practitioner will be called, the resident will be called, or it will be the nurse practitioner or the fellow who will be called, depending on what subspecialty coverage you have and what expertise you have available. And in other programs, they will want the attending called directly at this point in time. But clearly an escalation is needed, and someone who knows that patient well, who knows that patient's problems well, will need to be told when they become sick at that point. And likewise at 7. Nothing will be automated, so the CCRT will not be automatically called. If you don't want to call them in at 7, that's your decision. You know these patients best yourself. If you do want support because the number is 3, and because Steele's heart rate is 135, and ordinarily you call someone if they're in fast atrial fibrillation 135, then you can do that. It will not be an automatic thing. There will just be this guidance and this direction popping up. In addition to that, one thing that I think is helpful to know just using these scoring systems is you want to see what the trend is and you want to see what components have changed. So I think it's, again, we will learn the baseline of our patients. We will know that this patient has chronic respiratory failure. We know that they're awaiting transplantation. We know this patient has kind of acute confusional state. It's now become chronic effectively because they are waiting for a liver transplant. And we will learn that about them. But if something changes and their score changes, it's that delta that will be important to us. You want to be able to see the individual components of what made up that score. So this trend here will pop up. And you can additionally, you can add this to your summary screen as well, because there's a NEWS2 summary. So you'll see all the scores, you can trend all the scores, and you can see what made it change. So my baseline might be 3 because of my acute confusional state that's now established, and all of a sudden I'm 5. It'll be my respiratory rate that's deteriorated or my oxygenation that's deteriorated, and you'll know whether that's important to you and your patient or not. So all of this will come, again, the lingo is hover to discover, which if you have a British accent doesn't seem to rhyme particularly well, but it is useful just to be able to float the cursor over there and see what you need to see. And I think it's really actually much more helpful to be able to see the trend at a glance, to see the components at a glance. And wherever you hover over a NEWS2 score, it should pop up the components of that score so you can see why it's that score. It'll be a different color. Likewise, when you see on the, I can do it on this, can't I? You see here, 3 in a single parameter. 3 in a single parameter is much more predictive of a bad outcome. 5 as a cumulative score, but 3 as a single score. It's almost the equivalent in terms of what that predicts in terms of your outcome and your need for critical care services or admission. And so that will show up in a different color to say to 4 on its own. Even though it's a lower score, 3 in a single parameter will show in yellow. And then what we're encouraging people to do and what they've done at other hospitals like Hamilton Health Sciences, they've actually added this to your patient lists. They made it a compulsory sort of viewing delight for everybody. We're trying to encourage people to build this into your workflow. And certainly my use of this, I found it's actually very helpful to pull up in all of the patients who are under a particular physician's care. Or what I can do is have everybody, I call it my CCRT sort of list at the Western. And so I can look at this list and I can add NEWS2 to the properties of this list. I then drag in every inpatient unit that's being covered by NEWS2, and I can look to see what everybody's score is. And I can almost use this to predict where the CCRT activations will come. And it's interesting to follow people because you can see that those people are sort of sitting there top of the list. And obviously you can, as you know, you can order that list by patient name, by bed number. You can do it through NEWS2 score. And over the course of time, we may be able to do it through the delta of the NEWS2. So you can see it's the patients who are rapidly changing are the ones that you want to follow the most. But we'd encourage you, particularly those of you perhaps who are covering the whole of the multi-organ transplant program at night when you're on call, or you're covering all of the lung transplant program when you're on call, is that you have your patient list and you add this to it so you can see who the sickest patients are. And I'm sure you do the same kind of thing. I don't start my ward rounds at one end of the unit versus another. I started with the sickest patient or with the new admission who's often the most, person we know the least about, the one who's still evolving in terms of their pathophysiology. And you could do the same thing. The first 5 people you talk about during handover are the ones with the highest scores. If you find that that's not predictive of the people you're going to get called about overnight, do it a different way. But I think it's helpful to have an overview of your patients. It's impossible to have the detail on this overview that you really want, but to have the NEWS2 scores, I think is very easy. And again, when you hover over those numbers, it'll show you what's actually happening. It'll show that the heart rate has changed all of a sudden. And that's why they're suddenly scoring 5 when previously they were sitting at 2. If you don't see anything at all, then it means that they're not in scope, maybe because they're a palliative patient and you've made them not in scope of the project, or it means that they haven't actually had the orders put in, or they haven't had the vital signs, the full set of vital signs done. Again, the score will wipe after 12 hours and the scores will wipe at the end of the encounter. So if you look back to see what I was doing the last time you admitted me in my post-transplant first admission, that will be gone the next time you admit them. You'll have to go into that encounter separately to look at those scores, and the same as if you want to look at the vital signs and see what my blood pressure was on day 3 or whatever else it is. It's the same kind of principle. So as I said, I think this is where the workflow will improve for everybody. I think when you're seeing patients in the emergency room, you can carry with you every time you log in, you'll see these scores on all of your patients, and there will be a pop-up if somebody changes to the level of 5 or higher to let you know every time you log in. So to draw this to the close, this is being implemented. This isn't a sales pitch here today. This is really helping the program out by doing some of the teaching. We were very keen to sort of meet and greet and take questions directly with what we sort of regard as the big 5 programs. The Toronto General, you're very good for business when it comes to rapid response systems and intensive care. And the other way we look at it is there are certain programs that are already have an established partnership with critical care, already have existing highly tested escalation of care matrices as well. Multi-organ transplant, followed by general medicine, followed by general surgery, thoracics and nephrology here at this site. And if you take away nephrology and thoracics at Toronto Western, then it's neurosurgery and neurology, the 6th floor step-down unit that would be one of our leading partners there. So we're keen to sort of come and talk about this, but it is going to go live on October 7th. The order sets are already being changed so that they will seamlessly change at 1 minute past midnight on that day. And we're hoping that by midday that day, that every single patient that is within scope, which is all the inpatients, it's all those patients in the emergency room that you've chosen to admit. So as soon as they're admitted under Dr. Lilly or whomever it is, that person will be then part of the scope to be able to follow those patients down there. And roughly speaking, it's the people that would be covered by your rapid response system here, Princess Margaret, Toronto Western, and then on the same day, some of our TRI patients will be going live as well. And we're starting off with the most complex patients and those in the spinal injury unit there. I'm hoping that this is going to be an adjunct, not necessarily to the most experienced amongst us or amongst all of you in terms of looking after those patients, perhaps those have the least amount of experience. But to all of those of you who have the most experience, you're probably going to be amongst the busiest. And so it gives you that bird's eye view, the ability to be able to follow 70 or 80 patients at once, to give you some idea of their acuity, some idea of their changing acuity. Your clinical directors may find this an opportunity to reroute resources so that your patients who need it the most get more resources. It may be a means in which you can establish what the acuity across the program is. So when a decision is being made about level 2 resources, for example, you can make an argument, you can justify it within a business case to say, this is the area under the curve for patients who score 5 or 7 through the course of their stay. And I think that that should be directly proportional to the resource that you have for level 2. And maybe a lot of my colleagues in general medicine are feeling the same way because they still have an absence of a step-up unit here, which I think will be an asset to those patients deteriorating the same way as general surgery and other surgical teams and the multi-organ transplant program use that as well. It shouldn't be a substitute for clinical judgment. I think that's pretty dangerous if we use any one of these scoring systems for that. It really is just about how we communicate. It's about how, in the same way as we use a Glasgow coma score, an absolute number of 12 doesn't really tell you anything. You've got to break it down. You've got to describe the functional ability of that patient. It's not going to get a neurosurgeon awake in the middle of the night with just a single number. And this is exactly the same, I think. But I think it does help. It does help with the professional communication. It helps if somebody calls me and says, this patient's a score of 5, I think you should come and see them, that they put a little bit more meat on the bones. But at the same time, if they call me and they say this patient's score is 7 and they can't quite articulate why that person is sick, then I need to kind of reach out to them as well and recognize that not everybody has, 25, 30 years of experience in their role. And this may be the only way in which they can articulate in the same way as we would go and see patients as an intensive care team. And you would go and see patients when you get called by your colleagues because they're worried about them. They can't quite put their finger on why. What they're probably looking at is sympathetic activation and evolving pathophysiology that you can recognize from the foot of the bed. You can probably recognize from the way they describe it. And because of your experience in the role, you'll know exactly the top 5 reasons why this is happening and narrow it down to 1 before you've even done a single investigation. I'm hoping that this sort of fits in with your workflow. And as I said, gives you that ability to look after multiple patients at once, because no matter how slick you are, no matter how knowledgeable you are, that's the most difficult part of our job. So we are going to be looking at as we sort of work through this program, we've looked at the sort of the pre-go live data. We looked at that by program, by patient population. We're doing pre-go live surveys to look at people's workflow. These will hopefully be the validated surveys are distributed amongst all the clinical teams and all members of your clinical teams. We're very keen to do post-go live evaluations, both qualitative and quantitative. Alon Weisman is leading that part of the program. He's the work stream lead for evaluation, but he's looking for partners from every program, from the quality leads, the education leads. People are looking for bite-sized projects, perhaps, who are here for just a year or 6 months within the role they are, or residents, nurse practitioners, people who have support to do academic activity. I think that this is an opportunity for the organization because a massive amount of data will be available to everybody if it wasn't already, and ready-made alliances and collaborations to bring in some of the data that we're using from the critical care information system, from Epic itself. There's a lot of digital support. Significant part of the $500,000 we put into the budget of this has been really about the digital build, and it's been built with the mindset that all of this data will need to be interrogated, initially retrospective, but also prospectively as well. We're an academic institution. Our goal has always been that we would be leading the work to produce NEWS3 and all those separate iterations of that for the special patient populations that we have. We know we have the capability and the resources to do that, or even partners like Hamilton Health Sciences do not. So I encourage everybody who thinks that this is perhaps an interesting idea, something that might be useful for their patients and for their own practice, to work with guys like Alon to look to see how the build is coming in terms of this prospective work, and to start working with him and other colleagues so that we can put in the REB applications as soon as go live is completed. The second phase of this, once it's been rolled out across our acute sites, once the rollout has been completed around the post-acute sites, and that will be the spinal injury unit, then Bickle, and then the University Avenue site for rehab, will be to bring in specific tools. And the first tool that we're going to be adding to this that we're working on already in the build is a sepsis tool. So when you hover over, when you get an alert activation at 5, you'll be prompted to consider, do you have a pretest probability that this patient has an infection, that they have sepsis? You'll be led down that path to look at their SIRS criteria. And if you think this person has an infection, if you think this person could be deteriorating from sepsis, and I said the sensitivity of this was designed around picking up those patients with sepsis, then be provided with an order set that you can click on that will give you that immediate panel that you need to change that person's outcome. And it's the simple things we're not always sort of good at remembering, that not everyone we work with will have had the experience that maybe everybody in this room will have had. But it's about delivering oxygen. It's about delivering fluid resuscitation in an adequate amount. It's about escalating care so that that person's frequency of vital signs changes instantly, that a notification goes to the leadership of those programs so that we're looking for additional resources like level 2 beds or level 3 beds so you can change that person's disposition. And then having a set of antibiotics that you could start immediately with a couple of clicks, with a couple of sequential questions that bring in those resources from antibiotic stewardship, that bring in those resources from our infectious diseases colleagues, so that you can say, I have this patient, they're immunosuppressed, they have new onset respiratory symptoms, I'm going to start them on this in this first hour, and then this is the set of investigations that I want to have. This is the set of colleagues that I want to be called, so that you bring those resources in the second and subsequent 24 and 48 hours to that patient's bedside. So my goal has been, my workload has been creating this escalation threshold, aligning it with the numbers so that the numbers produce an appropriate proportional increasing escalation for that patient as they deteriorate. And now bringing in colleagues like Shahid Hussain, Miranda So from ASP and from multi-organ transplant ID, so that we can cover some of these immunosuppressed patient populations, those patients across the road at Princess Margaret Hospital, and then other colleagues from infectious diseases and general medicine and transplant, so that we have a sepsis tool that is appropriate for the majority of our patients here at UHN, that then gives you a rapid order set to treat that person, to resuscitate that person, to bring in the colleagues that you need. And then after that, then we can get down to the detail. in the same way as you might assess that person in the resus room as well. Is that a hand? It is a hand. Okay.
Certain information or tools that we can utilize. Does that sound correct in how we should be using this?
Yeah.
I guess the one question that I would have is that there have been a few times in the past 2 months where I've had patients would be classified as a NEWS of 7. And I found the rate limiting step to be that I knew they needed ICU. And it can take sometimes up to 30 minutes for CRRT to come. So I guess my question is, in those situations, should we be considering making it almost mandatory that it's an automatic CCRT consult? Because I go and assess the patient, I automatically know, and I'll try to do things to stabilize the patient, but I know they're not better served in that area. And the limiting step always is someone else needs to evaluate, then they discuss, and it can take time. So I'm just wondering, in that situation, I don't know what the time limit is supposed to be for them to respond to the consult. And I know things get busy, but I just wonder, in order to better utilize the services, especially when you're MOT and you're running around and you have a NEWS7, then should that be automatically almost mandatory for those patients? And obviously the MOT or the primary team will also come and you can discuss, but that was just a question that I had, because I've had a few patients that I've waited up to, honestly, sometimes even 45 minutes, and then you need a bed and it takes even longer than that.
Okay, so if that wasn't, I mean, I can hear you. I'll just repeat that. Your question is, because I put back up this framework here, and your question is whether this should be a mandatory consult at a certain point, and are there expectations in terms of how quickly that response should arrive? I mean, I think that's a very good question. As we've developed this, we've sort of taken a step back from that concept of mandatory consultation. I think that, so at UHN, there are guidelines in terms of your response and expectation to an urgent response or an emergency in the emergency room. And all programs will have the same numbers. So some people might argue 30 minutes isn't a long period of time. You might wait a lot longer than that and be doing CPR in the street if an ambulance arrived. For an inpatient, 30 minutes to get down to the emergency room for an urgent consult, the patient who's crashing or has potential to deteriorate to that point will be outside, I think, the expectations. I think to respond to that page and be down there within 15 minutes is the sort of expectation that Erin O'Connor would have, and understandably so. But over the last, so we rolled out CCRT here in 2005 as one of the trial sites in the province, and we still have the same model of care, which is one nurse with a ramp-up model, so that they will then take the call, they will see the patient, or they will take the call and then escalate it, so they bring in a respiratory therapist and a physician as well at the same time. And since then, they're seeing sort of 3 or 4 times the number of consults, new activations alone, plus all the discharge follow-ups, which is the other part of their role. And they're under-resourced in the same way as most programs are. I think it's reasonable that somebody sees that patient within 30 minutes. I think it's reasonable, though, that a lot of that resuscitation, if we put up an order set, say, for a sepsis tool, and we're going to put up those top 6 sort of things that you should be doing immediately, you're not going to be able to wait for a rapid response team nurse or physician to come and do those things. That's something that I think you're going to have to do as the first responder, and then we're going to have to follow up. And I think both of us, you as a physician or nurse practitioner, me as a physician or nurse practitioner coming from the ICU, we're going to have to up our game a little bit. And the only way we can do that in terms of resource allocation, and don't get me wrong, I'd love to have 2 nurses per day and per night. I think that would be a value add. And so the way we're modeling it in terms of the physician coverage, that's going to be dedicated day or night to those consultations and that role. But some of those resources aren't going to come quickly. The way in which we can free up some of those resources is really about preventing the deterioration. And it's about focusing those teams' efforts on those sicker patients. And the number of activations that are in the sort of the 1 to 4 is high. It's high in each program. And by freeing up that sort of time by hopefully having an escalation of care framework with local response that is enhanced to prevent the number of deteriorations that get to 7, this is the sudden change obviously you're going to have. Hopefully that will allow quicker responses and better responses, and a track and trigger system should allow you to track people and trigger with some degree of automaticity without making it a mandatory consult. For as many people who say this should be a mandatory consult, we should have the rapid response teams deploying and following these patients. There are as many people who don't want that for their patients. In the same way as back in 2005, there were a lot of people that had to be really convinced over a matter of years that having CCRT respond to their patients was a good thing for that patient and a good thing for that patient's outcome.
I think that's not the question. You know, we all like the CCRT and how it's organized. I think, as you pointed out, the capacity didn't grow with the demands in there. This is a problem in there. You know, that it's a good system for recognizing, but in the long run, we need to capacity. I think this is the point.
Right.
And the question is, if I see, sorry for jumping in there. I mean, I was following your presentation online before, but thought it might be good to come in for discussion. I mean, it's a great system. It's been proven in the NHS that it's working. So this response stages, they are all the same, all over UHN, right?
This framework here will be
like what you do if it's 3 in a single, more than 4 or more than 7. This is similar on all wards.
Yeah.
And, you know, the only thing, you know, when I saw this in there and thought, you know, half of our patients, let's say in transplant, which are very sick and often hit these, are either surgical MRPs or let's say most of these things of 7 happen in nighttime, but we always have someone from the medical team on board. I'm happy to be informed of this, you know, but in terms of doing something good for the patients, before a nurse starts calling the MRP at 3 in the morning, should be the local team, and then they are escalating to the MRP.
Yeah.
Just that we have this built in here. It sounds a little bit where the nurse is looking and who is MRP. I mean, we have local teams 24/7.
And that's who you'll use on your unit.
Okay.
So if the ward care is provided by the medical part of the transplant team,
So we define these paths.
you can define who these people are, who these roles are. Not every
Okay.
team has a nurse practitioner, and if you do, then that's
Okay.
an excellent
I
person
thought
to-
this is the same for the whole.
It doesn't have to be. I think there's some interpretation there. I think that there needs to be some interpretation there. Otherwise, a whole generation of learners are going to be skipped out, and a whole generation of people who are highly skilled and know a patient population like no other will also be skipped. And you can't have some of these direct calls to people who've done, say, the procedure, but not necessarily seen the last sort of 2 days of a deterioration or a change isn't necessarily going to be helpful or sustainable either. It should be left to some interpretation at local level.
Okay, very good.
Hi, thanks for the talk. We've got a similar kind of system back home in Australia. My question is, when we do MOT, we often, by the time we've just had a handover 20 minutes, we're just receiving, we might have 5 to 10 pages, and they all just come with the same numbers. So you don't really know, you could have a patient at number, you know, 5 out of 7 or something, and you won't know, and you might be answering 5 non-urgent pages first. Would there be any implementation for this where they can somehow, when the nurses are calling us to update us that they're concerned, that they can, you know, put in a score NEWS2-5 or something? Because often that might be the 8th page I get, and I'm, you know, spending time talking about a blood sugar of 13 for 5 minutes first before I get to the sick patient, you know, trying to triage these pages. Is there any way that that could somehow be implemented in as well, like with teaching to the nurses and things as well?
Yeah, I appreciate the feedback. I think we all have those calls, and that's the dross that you've got to wade through to get to the real issues. And 20 calls is still 20 calls, and then to tease out those 2 where something's changing. Hopefully this does help you triage the calls a little bit, and so the teaching that is being given to the whole of the interprofessional team is that some of these things help you recognize that a score, you know, blood sugar of 13 isn't on here for a good reason, because it's not necessarily going to change that patient's outcome. Whereas a cumulative score of 7 in the NEWS2 does predict that. And that's the sort of thing you should lead with. In the same way as, you know, I'll take 3 or 4 calls myself when I'm covering the ICU, and I'll have calls because this person's potassium is this person's that, particularly on days where everyone's at academic half day and we're doing the real work all of a sudden. And then you'll get to the fact that, do you think that's why this patient's got a heart rate of 39? Yeah, I think that might be the thing you lead with rather than just telling me that the potassium is 3. There has to be some ongoing communication. Even before you introduce something like this, you have to have that kind of working relationship and that kind of communication. And people need to learn how to prioritize this. So introducing this without that, I don't think will be a value add. And what is happening over the next 3 or 4 weeks, and Maria Nelson is the director of professional practice based at the Western, but across the whole organization, will be updates for the nursing staff about communication and about the head to toe, about how to deliver this information in a prioritized manner. It's not that people don't know that, it's just that you want that to be, you want something, an innovation like this to land on familiarity with the existing systems. So an update on escalation of care matrices for people, an update on SBAR, and an update on the head to toe assessments. And to some extent, sort of remind us about professional communication so that if you do call me at 3 o'clock in the morning, I recognize that this is a learning period. I recognize that someone is calling me because they want my help, as opposed to the 20th call that it's a score of 3. This will happen. But I think we just, build on the strengths of our relationships and our communication. And just to come back to the point that you made, the question you asked earlier about how CCRT can be helpful and how the system hasn't evolved over the course of time. Everyone's system has to evolve over the course of time. And when we rolled out the CCRT in 2005, I think they were doing roughly 80 lung transplants a year, probably a similar proportion of liver transplants as well. And over the course of time, all this activity has doubled, and as well as the number of patients who are inpatients at any one point in time, I'm sure the acuity has increased as well, because there weren't the community partners doing some of the post-operative or post-discharge sort of care as well. So at the same time as I need my program medical director to sit down and look at the resources that we have for the provision of intensive care to these patients, particularly those programs that don't have access to a step-down unit, we all need to look about how we're going to be managing these acute calls. If you're going to hand over at 5 o'clock and you're getting 20 calls, that probably won't change with NEWS2. Certainly the trial with GIM has not suggested that that number is going to increase. So far over the last 2.5, 3 weeks, haven't seen an increased number of CCRT calls either. Some of the language has changed, but not the actual frequency of it. I think those 20 calls won't go away until you have a system-based sort of change. We won't be able to provide a more rapid response to you within 30 minutes or within 15 minutes unless we have more resources or we direct the resources in a different way. I think we probably need to do both. I'm hoping that this enables us to direct those resources. I hope this revisits the conversation that we've had about preemptive rounding. So rather than the mandatory consult, that preemptive consult, and other hospitals have used this to give a site-based view. You look at everybody there, somebody hits 5, you go and see them. Somebody hits 6 or 7, the intensive care team goes to see them instead of the CCRT nurse or the CCRT physician. And certainly if I was on call and I was seeing patients with the residents or fellow, and they have 3 consults, I'm going to go and see the person who's scoring 7, who's on the transplant unit. They're going to go and see the person who's scoring 5, perhaps on the GIM unit. Depending on how we sort of have to divide and conquer, that might be the way I have to divide and conquer 3 simultaneous consults that I know nothing else about. Some of it will come down to personal relationships because you know the person who's calling. But if it's everything being equal, then yes, I'm going to use this. And in other hospitals where I've worked, where we have the EPIC deterioration index score, which is a little bit more, convoluted than this and not as established as this, you can look at patients, you can say, this guy seems sick, and then you can figure out why just from the data, then you go and see them, and then you've got the full picture. I think it may help in some ways. Now, again, it may help because we can sit there and say, you know what, across the organization, the Toronto General site, there are 3 times as many people scoring above 5 as there are at the Western. Maybe we need 2 nurses there covering the CCRT and a full-time fellow. We need 1 at the Western because it's quieter, and we just need to do preemptive rounds on the 6AB neuro step down. And I think a critical care executive, I could easily make those arguments right now. This will give me the data to make the business case. Has to go to the program level as well, where you have hospitalists in-house, the GIM, there may be other services, other divisions that have to think about the way they have their hospital at night covered. maybe the way in which we all work together to cover the hospital at night. I use that phrase specifically because that's what it's called in some jurisdictions around the world. But the escalation should be specific to the program. It should be specific to the patient population, the resources that you have. If you organize yourself in a certain way now and your escalation of care matrix is different to that, say, of general medicine or general surgery, it should be followed. It should align with this. And where it's not, then colleagues like Maria be happy to sit down with the APNEs and with the nurse practitioners, with the unit managers, and help all of you to align it a little bit more closely. And from today onwards, there should be some ongoing discussion amongst all of you to say, you know what, that thing Steele was talking about the other day, I don't think that's going to work for us. What we need to do is insert here and teach everybody so that when our trainees need help in the middle of the night, this is the way we escalate rapidly. And then beyond that, then we're calling the people who are involved in the original procedure, the original admitting physician, perhaps the longitudinal respirologist or hepatologist, and you have your own escalation the way you bring your colleagues in. I have no doubt that that's how a lot of our surgical teams at the Western we're doing the same thing as well. There are some additional resources that have been added in, and this will be distributed through the educational leads and the quality improvement leads for each program. Some of this is the quick start guide. I don't think I've dumbed it down at all. It's just one order set that you click on. You just pick which oxygenation scale you want, and the same as you pick your oxygenation targets now. But there is the formal EPIC guide as well. And there's some supplementary practice material, which I think is helpful. And it does speak to some of the broader terms that we talked about today, or the broader topics rather, about the way we communicate with each other and how our expectations have been that this might initially cause a blip in terms of escalations to the intensive care, escalations to the level 2 units that you have, maybe a few more calls to more senior clinicians after hours. That's our expectation, that our workload all might collectively go up by about 10% immediately after rollout. So far, with the GIM trial, that has not been the case. So far, the rapid response team calls has not increased. So far, the satisfaction surveys and the reports that we're getting from our nursing staff at the bedside, from the nurse managers, from the MRPs, is that that workload hasn't yet increased in that way. Again, that may be true for general adult patients. This is more designed for those general adult critical, general adult deteriorating patients. But I'm hoping that that's the same is true for some of our unique patient populations that we have, and we'll learn more as we roll it out and go live. Does anybody have any other questions? Can I bask in the glory of finishing early? Okay. Thank you very much.
Thank you.